We'll move on, and we have today with us as our keynote speaker none other than Professor Atul Kumar, sir. Uh, we are really glad, sir, that you are with us here today, and you have spared time from your very, very busy schedule. And sir would have to leave after the keynote address. So let's get the best of him. And the lecture that he is going to share with us today is going to be, as usual, his par excellence lecture. Thank you very much, sir. Professor Atul Kumar is the Chief and Professor of Ophthalmology at RPC, at AIMS, the National Apex Ophthalmic Center at All India Institute of Medical Sciences. He was awarded Padma Shri in January 2007 for his services to the medical field. He specializes in vitreoretina surgery and also heads the vitreoretina, uvea, and the ROP services at RPC. And as we know him, not only he is an excellent clinician, but a teacher par excellence. So whenever we hear Professor Atul Kumar, it's a talk that we remember for lives. Thank you very much, sir. And we request you to give your keynote lecture, sir.
Thank you, Partha.
Yes, sir.
Sharing screen. So I'll start.
Yes, sir.
Yes, sir.
Okay, so I'll go through my lecture, and I hope I can pass the message which I have in my mind across. And we take things like AMD very lightly. For years together, for decades together, we faced this problem of AMD more in the West, but now there's an aging population in India itself. People crossing 70s, 80s, going into the 90s. So it's common in India, which wasn't so few decades back. So it's become an enigma how it happens. What are the kind of presentations? What variants are there? I mean, what you don't expect happens, and all of this I just put together in a lecture. So I thought I'll just share with you that this is not a very easy disease to treat. I mean, not so tough also, but it's not just anti-VEGF and that's it. So it's the biggest problem is it's increasing blindness, because as Maipal and Partha also said, and everybody, that there's increasing aging population, and if you go to the there's a increased prevalence of the aging population. Global prevalence is about 8.7%, and there's a good 50% increase.
Slide share is not done, sir. Excuse me, Atul, sir. Slide share is not visible.
Yes, sir. Okay, 1 second. Now it's...
Yes, sir.
Yes, sir. Now it's visible.
Yeah. So you got a global prevalence of AMD about 8.7%, but it's going to increase. Like diabetic retinopathy is a little lesser age group, but AMD is something which is a silent blindness. Diabetic retinopathy, you have systemic symptoms, you have ocular symptoms. Patient comes with floaters, this, that. The AMD doesn't have floaters. It's gradual loss of vision. It's painless. Diabetic retinopathy may have, today only I saw in OPD, there was iris rubeosus frank. So people don't know what is iris rubeosus. It leads to neovascular glaucoma, and then because of the lockout period, they lost their vision because they never ventured out of the house since February, March. So with the aging population, India is going to have a problem. We've had a AMD study in eye, and they say it's similar, but grade 3 appears to be lower. But this could be fallacious because, as was mentioned by the President AS also, that there are difficulties in testing for retina. It's easy to test for cataract, even in a RAB survey. RAB survey is a selected survey in a population. The RAB survey is a quick survey to find out what's the prevalence of a particular cause of blindness. But its problem with AMD is that you have to check the retina. You have to have trained people. So we have lack of trained personnel for retina. You have lack of resources like examination, imaging techniques, because whatever said and done, FA, ICG may be required at the primary health or at least the secondary health centers. You might require an OCT, which is very, very important, and OCT-A also. And if you have the same machine incorporates autofluorescent imaging is better. So you got a multimodal imaging system where you can do all these tests. Only then you can actually define whether it's neovascular AMD or dry AMD or something else. It's not AMD, it's something else. So it's very important. And therefore, I think we don't have the requisite personnel, the imaging techniques, and often we don't know what's the cause of visual loss because we just say it's aging and it's probably choroidal sclerosis or the nerve is not improving. 618, 624, it's fine. But actually maybe having a gross AMD at the back which progresses because of the cataract surgery. And there's a lack of awareness. So though the classical pre-AMD drusen are this way, but there is another thing called pseudo-drusen, and pseudo-drusen are present above the RPE and they present with these sharp elevations, and it's like a net. It's like a net all over. It's not as diffuse. Drusen is not as diffuse as the pseudo-reticular drusen. They also predispose to a lot of AMD. So you got to see both these things together. You have to know these things. So personnel have to know this. Now sometimes you get a picture like this in a patient and you check for cataract and it's there and you think it's probably diabetic retinopathy. You get his sugars, it may be still normal, but still. So it's very important such patients get their OCT done if it's possible through the cataract. You'll see it's not a diabetic maculopathy at all. It's not a sursnet ring. It's got a PD, fibrovascular PD with multiple PDs along with it. And it's got serous fluid. It's actually a wet neovascular AMD or a polypoidal choroidal vasculopathy. And the same patient showed the branching vascular network and probably a polyp over there. So both eyes are presenting with a picture akin to kind of these exudates, hard exudates. So hard exudates is actually a picture not only with diabetic retinopathy, it's also with neovascular AMD. So you can have, this is a picture of a patient which was very shocking and surprising to me. He was doing very well. This was his state in May. He had a type 1 CNVM sub-RP, there's a little double layer sign, and he was doing well. I told him that we've had your injections, we'll wait. This was his octa picture, OCTA. You see the huge neovascular network going from the superior arcade vessel, main temporal vessel, to the inferior. So I didn't give much importance. I said, there's no fluid, so I'm not going to treat. He came back within less than a month with the bleed, and he had this neovascular AMD, of course, was there. And this was the RPED, which came up from here. And you can see the subretinal hemorrhage all over. So he actually lifted up his fovea and his vision went down to hand movements, and he was grumbling, cursing. What happened? So what I realized is not only the SRF is important, but now I take OCTA into absolute consideration. So we'll have to take the OCTA and check for the size of the neovascular membrane. I don't have guidelines right now, but I feel a large neovascular membrane on the OCTA, which is non-invasive, very acceptable to the aging population, may be the guideline in future also, not only the subretinal fluid, but also. So what happens is when you have a neovascular membrane and you have this PD and you have probably the occult type of a CNVM, you have these deposits over here and you have these deposits after you treat it. Now don't ignore these deposits. There is something called SHRM. This is subretinal hemorrhagic. These are small deposits over there. It's a hyper-reflective material, and they actually tell you that this patient has a relatively poorer prognosis to anti-VEGF. He's going to end up with more chances of foveal scarring. So SHRM or subretinal hyper-reflective material should be looked for. Now these things are very important because the prognosis of the patient depends on it. So this is a unique thing which is happening, that these are markers which tell you. Now, there's another very interesting thing which is happening recently from New York. They've reported this, and it was actually reported in 2014. But we've got to look for it. There's a multi-layered PED in neovascular AMD, and I'll show you the picture right away. This is the multi-layered PED, and it's got a choroidal cleft. This choroidal cleft is known to be present in patients who receive chronic anti-VEGF therapy and they have a fibrovascular PD. So you can treat again. So this is a chronic fibrovascular PD with a choroidal fluid over here within the choroid. Now, sometimes when you give chronic injection, this is two things very important, which from the point of view of cataract surgery also, that this patient had cataract. He wanted to get his cataract done for dense PSC, but he had this at the back, choroidal cleft, and multiple injections given of fibrovascular PD, and he had a rip. He had a RP rip. This is an enigma. I mean, we don't know why these rips occur. They occur spontaneously. If the height is more than 500, the risk goes up. The height of the RPD, RP fibrovascular PD, if the height is more than 500, less than 500, 400, they say it's 10%. 600, it's more than 43%. So with anti-VEGF, they say the risk goes up. And that's what's been reported, that if you give multiple anti-VEGF injections, like this patient received multiple injections, they suffered a rip. So he said, my vision is distorted. I'm not happy. I'm not happy in this side. Other I am happy. You see the RP rip on the octa and RP rip on the FA also. So the same rip which is seen on the clinical photograph is there here, and actually it's ripped here. So you have multiple problems. You have a multi-layered PED, fibrovascular PED. You do the cataract, he may bleed. And you've got a patient who's not going to improve vision. He's going to have distorted vision after the best of cataract surgery because he's got a rip. So these are the things which are very important that we have got to see along with cataract surgery. So these multi-layered PEDs, we just kind of looked up the literature at RPC, and so we found that these fibrovascular multiple bands have contractile properties, and this, when they shrink, when you give multiple anti-VEGF, the vascular component shrinks and tears the RPD, and you get this prechoroidal cleft. So this is what happens: is a type 1 CNVM, and you have multiple under the PD. You have a type 1 CNVM. You have multiple fibrovascular tissue, and this is a choroidal cleft. This is another case of ours. So we're looking at this more carefully now. You can give them anti-VEGF, but vision-wise, probably they won't improve much, and they can bleed also because they're fibrovascular PD and they can rip. So RPTs are very important. They can occur, and we have to know this. Even cataract surgeons should know this, that if you inject repeatedly in somebody who's got a pigment epithelial detachment which is high and tense and like a bleb, like a, you get warm fluid on your liquid on your skin, you get a bleb. So if you got a high bleb, you might get an RP tear. And this may happen during cataract surgery also, because it is known to happen spontaneously. The PVD occurs and you may actually create an RPD, and the patient may get worse vision after cataract surgery when he actually had better vision. So you'll have to discuss all this. This is another patient who had cataract, and of course he had a choroidal cleft here. So I won't go into this. The first line management, of course, is anti-VEGF, either give it monthly, treat and extend or pro-re-nata, or treat and observe. Treat and extend become very popular. And this is a neovascular membrane, and it's probably PD and fluid, and we treat. And this is what happens usually. We treat with anti-VEGF, there you are, patient is fine. Either you do PRN dosing as and when required, or you do treat and extend. Some people for a PRN, so it depends on what. Come back for 1 month for OCTA, and probably now OCTA. So this is the usual what we do. But it's more than that. You actually have to see how often do you want to see the patient who's suppose operated for cataract. This is post-cataract surgery. Even then you will have to be careful, because you're the one who operated the cataract surgery. So he's going to be talking to you also. He says, now my vision has dropped. What's happened? So you've got to have a retina consultant with you, a retina specialist who's really good at looking at the macula. Because periphery is fine, but macula, looking at the macula and looking at AMD is not a kid's job. AMD is easy to see and looks very easy, but actually it has a multiple complexities with it. So like I said, RIP is one of them, and multi-layered PD is one of them. And you can have a no fluid large CNVM on a OCTA. So OCTA, I think, has become necessary. So this was an Altair study done in Japan only, treat and extend, they found. In AMD 2 and 4 week extension protocols, that means once you treat after 4 weeks, you don't treat if he's fine, and then give them 2 weeks gap or 4 weeks gap extensions. They found they were both equally effective. So these are some studies. A choice, of course, for a cataract surgeon, he's got to charge for that, and then he's got to there will going to be charges for the anti-VEGF also. Ranibizumab is effective. For this slide I'm talking, and bevacizumab is also effective. It's slightly economically cheaper, definitely. But there's a problem with bevacizumab. It's not a single dose. It's multi-dose ampule. The risks of cluster endophthalmitis and compounding issues are there. Even in the US, they've had scattered issues of compounding and infection occurring even in a place like US. So there is a little risk with bevacizumab, but of course, at RP Center, we create our own ampule. So, but of course, it's a problem. But most of the studies, the CAT was the main study done in the US. IVAN was the UK counterpart, MANTA, GFAL, UCAS, just to complete the literature. bevacizumab was not inferior to ranibizumab for AMD, neovascular AMD. So the CAT study showed that it was non-inferior. But serious adverse events occurred at 24% for Avastin and 19%. The Avastin showed more serious side effects besides the risk of end-offs is there. So the aflibercept is added to the armamentarium, and we've got a VO1, VO2 study which showed us, because these trials are very important. They tell you what is, if something happens, you can tell the patient this is the trial which actually showed us that aflibercept is effective. So aflibercept really acts very well on neovascular AMD, especially polypoidal choroidal vasculopathy. It's a comparable injection to ranibizumab, or even better. And this is brolucizumab, which has recently been introduced. There's a lot of controversy if I say anything about it, because it's a low molecular weight, very high penetration into the retina. There are two studies which have actually shown that it's non-inferior to aflibercept. Aflibercept is the most potent anti-VEGF we have now, the brolucizumab also. So we need to have, the cataract surgeons have to have this basic knowledge that there is brolucizumab now introduced in India, but there's a big but here. AS, American Society of Retina Specialists, have shown there is a 4% increased risk of inflammation, which is 1% for aflibercept and 4% for brolucizumab. Second is they've seen 14 cases of occlusive retinitis. So that's 1% of patients. So that's going to be a little, elephant in the room, because you don't know if if the patient falls into that 1% or 4%, he's going to be troubling up the doctor, and he's going to lose his vision. He gets occlusive retinal vasculitis, he's going to lose his vision completely. So the issues with the anti-VEGF therapy, don't take it lightly. Anti-VEGF, before cataract, after cataract, okay, it's fine. But the thing is, the duration is very short, and 30% lose vision despite the anti-VEGF. That has to be told due to inadequate response, or there is for progression to fibrosis. So either response is less or there's a response. So it's easy for Novartis or Bayer to say that, we give this injection, we give that injection. But what is going to happen with those injections? Either you get the vision may not improve at all. So many patients come there, visions are not improved. In fact, the quality of vision has gone down. More than half of them, the quality of vision is very important. I can't see contrast. I can't read my book. 70-year-old man, 80-year-old lady, she's going to want to read something. She wants to watch TV, but she's not having the vision. So finally, what do you bank upon? It's a big problem. So the burden of treatment fatigue with anti-VEGF is there, and some opt to discontinue treatment. I'm not going to talk about this. I come straight to this variant. Again, we have an enigma. Neovascular AMD has a variant which is very, very menacing and present in the Asian population, Japan, Singapore, Taiwan, and India. I won't name China because we all know it. So polypoidal choroidal vasculopathy is a problem which is seen in the Asian ancestry. It's either a standalone variant, a lone entity, or it's a variant. Most people think it's a variant. And it's got features of pachychoroid, thick choroid, and it's got PEDs like you saw in the previous OCTs. It may masquerade as CSC because initially it may present with anxiety, lack of sleep, and that leads to CSC, central serous choroidal retinopathy, or CSR, and that leads to PCV. So this is the kind of a picture you can get. Patient comes to you with blood, he may be having a cataract. So you got to get the macula examined, and you may have actually polyps over there. And these kind of patients have multiple PEDs, and they've got this subretinal exudative fluid over here, and the hemorrhage also with the hemorrhage. So these are kind of patients, you have to treat surgically. If the macula is off and the vision is affected markedly, then you have to treat anti-VEGF. So this is another patient of PCV. You can see the polyps, which are classical, and you've got this branching vascular network, multiple polyps. And you see the classical thumb-like PD with the multiple thumb-like and a notch, and you've got subretinal fluid. So these are type 1 neovascularization with PD, and this is classical. And this is another patient with polyp, which actually got shown on the Octa. Octa picks up high flow lesions, but the polyp is a low flow lesion, picked up an ICG best. But here because it was so large, we did the manual segmentation, and we could pick up the polyp on the Octa also. So you have to have the OCTA. And so I won't go into these trials. The photodynamic therapy is one thing which works in PCV. Luckily, we still have that dye because Novartis is withdrawn, left themselves from the dye. They've given it to somebody, I don't know who. Each time I ask them, you're marketing brolucizumab, but tell us what is happening to the photodynamic dye. Because photodynamic dye is vision, it prevents blindness. It is very, very important to have photodynamic therapy. And they have to answer for this, because I'm talking in front of the AIs because we need this dye very badly. And without this dye, the PCV patients may actually bleed finally, and they're either going to spend every 43,000 rupees cost price for anti-inflammatory. And PDT actually cuts down the number of injections, and plus it improves vision also. I've seen so many patients with my personal experience. So we got to have photodynamic dye, which is not forthcoming from the Novartis people. It's a big problem. So this is another, RAP is another lesion which is a variant like PCV. It's type 3, that is intraretinal neovascularization, and you got intraretinal fluid, and you got a PD. So I'm just not going to detail of this. So these are newer things which you are seeing, the port delivery system, ranibizumab. But it's like a ganciclovir intraocular device, which was earlier, right in the beginning, it came out for CMV retinitis. So I don't know how many people would like to have a port made and put this, device inside the eye. It may lead to endophthalmitis, it could lead to ardent detachment. But anyway, this is one of the things. Now, this is one of the most important slides I want to tell you. Only anti-VEGF is not going to help our patients. Please, you have to have the anti-angiogenic drugs. Anti-VEGF will only inhibit the VEGF-A, all the isoforms. So now they're targeting the angiopoietin. The angiopoietin pathway is totally different, the Ang-Tie signaling pathway. And Boulevard study and a couple of other studies which are coming up, there's a drug called faricimab. I don't know who's going to market it finally. But faricimab is a one molecule, two targets. It's like kill two birds with one stone. So it's got anti-Ang, anti-VEGF. So we could eat something like this, because what it does is it destabilizes the blood vessel so that the anti-VEGF can act very well. So we need something like this. As long as it doesn't cause intraocular inflammation or occlusive retinal vasculitis, we could be very fine with something like an anti-Ang. I have no proprietary or any kind of financial interest in any of them. These are all in trials. This is a phase 2 trial on. So this is one molecule. All these trials have been done in the US. Let me tell you anything. Nobody to beat the US. All our latest material is coming from there. Whatever sent on the medical material or the ophthalmology material is the maximum from the US. Okay, so gene therapy is going to be there, target immunotherapy, stem cell therapy. Basipar was being developed by Allergan, but FDA has refused. They've said the risk-benefit ratio is very low. There are more risks than benefit. It causes, again, occlusive retinitis. It causes intraocular inflammation, like rolosuzumab. So they've refused granting permission. So we'll have to look for something which is combination of this two, because until you don't block this anti-angiogenic pathway, Ang-Tie 2 pathway, it's not going to help. So this is the last thing which I do very often. I've done about 200-300 cases. So whenever a patient of bleed comes, like the patient who had a huge CNVM but no fluid blood membrane, this is a smaller CNVM, but fovea was involved. So I'm just showing a small clip of 5 seconds before I end, that this is what I do. I create a PVD, then I inject with a 41 gauge cannula. I inject a recombinant TPA at the concentration of 12.5 microgram in 0.1 ml with Avastin, double dose, 2.5 milligram, plus a little bit of air. So you can see I do the IOCT to see where the PD is not there. So I don't go sub-PD, I go subretinal. And from there, I just create a big mound, which contains some little blood will come out, because that's the blood over there inside the subretinal space. With this is the air finally. So this is the kind of mound which comes in, and the patient sits propped up, and the results are very good. So these are unmet needs, high burden, transplant. Patients got very unhappy. He's going to come again and again for injection. So we want, this should be a longer acting injection or more effective injections. This is the kind of picture which we get finally when you treat patients for long. You come up with scars. And this is just telling you that gets, very bad. And subretinal fibrosis are very high. And this is the final slide, that this is a very important thing when today only that same patient told me, the subretinal bleed patient who had a large octa CNM, can I use some magnifying aids? I'm very fond of reading. So these assistive devices, assistive technologies would be very important till such time that we have something. So right now we don't have a magic cure or effective cure at all for AMD and for neovascular AMD. And for dry AMD, of course, the visual loss is very less. They can be managed. With neovascular AMD, visual loss is profound. So with cataract, we have to see the macula very well, especially for AMD, and try to, understand many of these things which I've just discussed. Thank you very much. I hope I haven't crossed up time too much.
Oh, sir.
Thank you, sir. Thanks a lot for the wonderful talk. We have the discussions now. Dr. Mahipal Sachdev, Dr. Natarajan, Dr. Lalit Verma, and Dr. Shobhit Chawla for the keynote address of Professor Atul.
Thank you, Atul, for a wonderful briefing on the AMD and all the varieties you showed, the mimicking AMD as well as the PCV and also masquerading of CSR, the role of PDT. And I think it's really amazing. And in case I think Vetoporfin is not available, maybe we can think about the ICG. And
we need Vetoporfin badly.
Yeah, and ICG guided.
How will you treat a PCV case? Repeated injections you'll give. After that, there'll be a stage when you like to do a photodynamic therapy. The dye is not there with them now.
I know. I think this is a problem with the commercial companies. I don't know how to. Maybe AIMS can do something, or a RP Center can do something. With of drugs. No. Okay. I think it's good.
Listen to AIS.
Okay. Good homework for I think Namrata and Maipal. But I think the best thing you brought out is about all the latest things on including the future drug, which is not but
anti-angiogenic drugs.
Yes, and it is very good.
VEGF is not the only answer. There's another pathway, angiopoietin pathway. So that's not inhibited by any of the anti-VEGFs.
Correct.
I think the way forward will be an anti-VEGF and an angiogenic combination. If we are not going to have PDT, it will have to be a combination. Maybe something as a sustained release implant and something as an injection. That's what comes to my mind, seeing the severity of the PCV cases and the numbers we are now identifying more and more in our country.
Absolutely.
And I think the other thing which you said is, which I always tell the fellows in my hospital, that they're treating AMD and finally you dry it out, or maybe after a few years, and don't say that the whole disease is gone. Make sure the patient comes for follow-up. And I think you rightly pointed out the last 2-3 slides about low vision aid. And I think it's important where I tell the patient that you can bring down to 636 and give them LVA. They can even have 6/9 in whatever restricted way, as well as the N5 using the various types of LVA. And I think it's very important. And I keep telling my optometrists that you should spend more time, and even the fellows, and encourage the patient, because don't compare what you had 10 years back and I want to read and I want to say my like it, but still you can use the low vision aid and do your work, sign your checks, and keep abreast with their knowledge. I think wonderful, Atul. I think as a veterinary surgeon, people otherwise think we only do treatment and surgery, but I think you have rightly pointed out to the anti-segment surgeon that when a patient has low vision, send them to a low vision clinic or to an optometrist and make sure they see better. And I think it's important because there's also a trial of intraocular lens for AMD patients with the telescopic intraocular lens, but it didn't do well. I think cataract surgeons were doing it. But I think finally, I think we have to probably prepare the patient that it is a lifelong disease and you have to keep checking. And as you rightly said, it's not an easy disease. Same time, it is not to give up. But I think the cataract surgeon also probably should expect, as Lalit said, there is definitely an improvement possible. I think when the cataract you do, and make sure that the patient comes for follow-up. And I think many times it shows that as though we are soliciting patient to come back. But I think they have to understand ARMD is related, and they have to keep coming to the doctor.
Amsler grid can be given to them.
Yes.
Amsler grid for screening.
Right. And that's why I have a first Amsler garden in the world, which is a vertical garden in the hospital inaugurated by Neil Bressler. And I keep telling, and I make it a point to give it, and also had that the PHP. But it's not, again, the sites has stopped making it, and the US tried making as a nodal company from Israel wanted to do a home monitoring using the PHP for monitoring, but it's expensive. But I think the simplest is the Amsler, and every patient forgets to use it. I always tell them, put it on the mirror when you're going to do shave, cover one eye and check. It takes only 5 seconds. And I think every anti-segment surgeon can tell that, so that both can have patients. I know Professor Atul is in the institute, but it's not only getting patient, but I think we're helping the old patients for seeing better. And I think he put a slide on QOL, quality of life. And I think there are a lot of studies both in India and abroad, and Arvind has done it. And I think cataract surgeons have to help that quality of life can be improved in an AMD patient. Maybe he'll have color contrast problem. But if he has a regular treatment, I won't tell, I have a VIP patient who's coming for almost 16 years every month, very meticulous. And that's why one eye is maintaining 6/6 and other eye is 6/36. He said, my left eye is gone. But I said, no, 6/36 to maintain, I'm still giving you anti-VEGF injections.
Right.
Thank you very much, sir. Sir Maipal, sir, from the cataract surgeon's point of view, your comment, sir.
Well, I think from a cataract surgeon's point of view, the only thing which Lalit told me the other day, which I'm not very sure, he says that the number of intravitreal injections has increased beyond the number of cataract surgeries that are being done every year in India. So I don't know what is the number of intravitreal injections if they are more.
Because the same patient we inject every month.
No, that is fine. That I agree. So that means that you are close to, you are above 6.5 million, right? So
that is true,
I
actually.
don't know. Sorry?
The number of injections has overtaken the number of cataract surgeries all across. Number of injections.
Yeah.
So
that is, per patient will have easily 20 injections. 12, some patients will have 12 injections, some will have 6 injections.
Whereas they will have only 2 cataracts.
If I can make a point here, is the gene therapy where you can just give a single injection and it seems to work forever, actually. So that seems to be very promising. I don't know, Dr. Atul could speak something on that.
The economics don't work out because it's so expensive right now and still in the experimental phases.
Yeah, it is experimental, but it would be a one-time treatment.
A one-time treatment, but we have to see the future, what it holds. But this like we have a angiopoietin pathway which can be inhibited plus the anti-VEGF pathway, then we can maybe have better results.
Can I ask Dr. Atul a question, Dr. Parker?
Yes, sir. Yes, sir. Please.
Atul, what do you feel about the emerging role of therapy in dry AMD? Taking Malika's question forward and the role of gene therapy in it.
There's a lot of interest and work going on dry AMD in the US using gene therapy for dry AMD. So dry AMD visual loss is not so severe, but they're still going to treat dry AMD because there is a population which suffers from dry AMD. But usually I see it's a combination of neovascular dry. I don't see dry so often. It's the scarring which see. The neovascular is what is seen more often. I don't think dry AMD patients actually come to you only because they have a mild dysfunction. The fovea actually may not be involved only sometimes in dry AMD. So the neovascular AMD patients are the ones who are really upset and they're unhappy and their quality of life goes down.
So my point was that when we identify them at the outset with fovea not that badly involved with autofluorescence now, those are excellent candidates for preventing further visual loss.
Yes.
They have cataract surgery in conjunction later on.
Yes.
Can have an excellent, long-term prognosis if we have a therapy.
Absolutely.
The other one, fortunate, I think US has more geographical atrophy compared to India, where we did a study between Cleveland and Mumbai, and we found we don't see that many geographical atrophy, but they see a lot. And I think that way we are, better off here in India.
But we got a lot of polypoidal choroidal vasculopathy.
Yes. Yes.
Yeah. So, sir, I think from your very scholarly talk and a very practical talk also, all of us cataract surgeons do get the point that it is so important to actually not only very carefully see the fundus and the macula, but also do the imaging of the macula before the cataract surgery if there is any doubt of the macular involvement of anything. Yes, Lalit, sir.
Yeah, you see,
Dr.
what Atul has done is that you see in 20 minutes, nobody on the earth can summarize AMD so well as Atul has done it. So congratulations, Atul, for this.
One question I have for Atul, sir.
Couple of points I would like to make is, because all cataract surgeons are hearing this. All cataract surgeons, before they do all these premium IOLs and all this toric and blah, blah, should always do an OCT first. I think he emphasized that.
100% we are doing it.
OCT first. Okay. First point is this.
No, but Lalit, why are
I'm just coming to
why premium IOL?
All IOLs.
Why only premium?
All IOLs. No, I agree. No, all IOLs. All cataract surgeons should have in their pre-op package. OCT is a must. Whether chargeable, not chargeable, you decide.
I agree.
Second point is, Atul will agree for this. Second point is that there is a lot of abuse of anti-VEGF which is happening. Atul, you will agree with this. We see every Tom, Dick and Harry keeps poking needle inside without understanding the disease per se. भाई 2 इंजेक्शन लगा दिया फिर भेज देंगे अतुल के पास, उसके बाद हेमंत के पास, whatever. You see, the understanding of the disease is a must. before you poke needle inside.
Absolutely.
So there's a lot of abuse. Therefore, I have kept one talk, abuse of anti-VEGF agents. Third point is, which he also mentioned, is the newer drugs need not necessarily be better. You see, brolucimab in October, American Academy was launched, with a big fanfare. But occlusive vasculitis creates scare out of you. You see, because these patients, ARMD, if they become blind because of occlusive vasculitis, you see today, brolucimab is claimed to be a wonder drug. In US, people are shifting, but they have a scare in their mind. No, Atul?
Yes.
Because it's not, you see.
The intraocular inflammation is more.
Yeah.
4%.
Apart from inflammation, occlusive vasculitis, I'm scared of. You see, if you ask me to inject, I will wait. So with these 2-3 points, and he very rightly said that faricimab first came for diabetic macular edema. And after showing great results in diabetic macular edema, now people are trying for ARMD also. And there are, phase 2-3 trials have begun for that.
Yes.
And we still have ray of hope. AMD patients still can see. That should be a message made that the prognosis have improved for last couple of decades. No longer AMD patients, unless until is going to atrophy, but a huge number of AMD patients, we can improve the prognosis by careful following. And the way to go is treatment extend kind of regimen. I think that he also hinted.
Yes.
Thank you
very much. Atul sir, just from the anterior-segment point of view or a cataract surgeon's point of view, two questions to you. You mentioned about the choroidal cleft. So what precaution would you like to tell the cataract surgeons in a case when you have a choroidal cleft due to repeated injections? Second question is, if you have a RP rip, how would you tell the cataract surgeon to manage his cataract, or what precaution to be taken in a patient with RP rip?
He's got a very high tense PD. The only option left, the very good question you asked. Either you can leave it alone, but fibrovascular PD, usually it is meant to be treated. But you have to tell the patient that there is a chance you've got a huge swelling on the retina. You'll have to talk in layman's terms, show the OCD to him, discuss it and counsel him that you got a huge bleb, and tell him the height is more than 500 micron. They'll understand. Tell them that this injection, which we'll give you before the cataract surgery, or otherwise also even after cataract surgery, can tear this bleb, because the vascular channel, the vessels shrink, and there's tangential traction, the RP rips. So there is a very high risk of ripping, and they will have distorted vision. Though the anti-VEGFs may continue, but their vision becomes a little distorted. So we'll have to tell them that, because this is something still we don't have control of. To prevent RP rip, we don't have any control, the retina beam, because it can happen spontaneously. It can happen after anti-VEGF, but they say the incidence is more after anti-VEGF. So I think we'll have to discuss it with the patient that the RP, if the elevation is there, it may rip.
Any intraoperative precaution for a choroidal cleft because of repeated injections?
You can give an
cataract surgeon.
Give an anti-VEGF at least week, because anti-VEGF acts maximum on 10 to 14 days. So give it at least 10 to 14 days before. 2 weeks before you give an anti-VEGF.
Okay. Thank you, sir. Now we'll go to the next question.
1 minute. One important point which Atul highlighted, which I noted down, I forgot to tell, which I am enjoying using the OCT angiography. As you rightly said, the net is seen better than, we're not doing angiographies now. Very rarely we do ICG also. But I think OCT angiography has a role, but maybe many don't have it, but at present it is academic. But it's really great to see the effects of anti-VEGF and any anti-angiopoietin also to use in the OCT angio in the ARMD. I think it's a real excellent point. You didn't spend much time because of the time limitation, I think. But I think
because of paucity of time. Yeah. Thank you, sure. Thank you, Natarajan sir. We'll go with the next case presentation now. We took almost 1 hour. Very good talk, Atul sir, and very great discussion.